Good morning, everyone. Good morning. Welcome to Pediatric Grand Rounds. Thank you for joining us. If you're anywhere near the Tanglewood Complex, please join us in person in the Mill Mountain Conference Room. And as always, we thank you for joining us online, wherever you're signing on from. Today's speaker is Dr. John Mark Stone. He's part of our Pediatric Gastroenterology department. He received his degree from the West Virginia University School of Medicine and went on to Kentucky Children's Hospital for residency and the University of South Carolina for Pediatric Gastroenterology, Hepatology, and Nutrition Fellowship. He's been with Carilion Clinic since August of 2021. His interests include IUD and education. Please join me in welcoming Dr. John Mark Stone.
Thank you. So this morning we're going to talk about over-the-counter GI medications and supplements. It's a pretty broad topic, so this isn't going to be by any stretch of the imagination a comprehensive review, but we'll talk about a lot of those things. So as far as the objectives, I'd like to outline common over-the-counter medications and supplements aimed at GI symptoms. We're going to analyze the available evidence for proposed components, the proposed indications for those medications or supplements, and the evidence available for efficacy, if there is evidence available for that. We're going to try and summarize some of the principles guiding the advantages and disadvantages of self-medication for our patients. And then hopefully, this is more an objective for you than it is for me, because obviously you're coming from different backgrounds and different types of practices. But as we go along, I'd like you to kind of think about some of the things that we're going through in order to kind of devise a plan for implementation into your practice. So think about the ways that these over-the-counter medications or supplements may fit into your practice or not fit into your practice, how you counsel a patient if they come to you and they're already using one of these medications or supplements. So just keep that in mind as we're going through. As far as any disclosures, I have no financial disclosures. I am going to mention a lot of brand names kind of out of necessity. You'll see I use a lot of charts. I kind of think through charts. That's I'm a visual learner, and so I apologize for the really busy slides that have charts on them. But out of necessity, some brand names are going to be used whenever I'm able to. I'll use the active ingredient, and I'll list a lot of medications underneath of that, or a lot of supplements underneath that. But for some, the brand name it kind of has to be used because there's multiple ingredients. And then also, this is not a political talk by any stretch of the imagination. I'm completely trying to remain completely unbiased in that regard. But because we're talking about supplements, federal entities and regulations are going to be mentioned. So keep that in mind. With that in mind, I'll go over the definitions really quickly. I think we already know what an over-the-counter medication is. It's a drug that's formulated to treat a specific symptom or condition that's available without a prescription. Keep in mind that that's really two subcategories. So that's going to be medications that were initially required a prescription, and then over time they've been approved for over-the-counter use, and they've been transitioned to over-the-counter use, so you don't need a prescription. And then there are other drugs or medications that have been formulated specifically for over-the-counter use, so they never required a prescription. And then the definition of a supplement from the Dietary Supplement Health and Education Act of 1994 is extremely broad, kind of vague, but here it is. Products intended to supplement the diet that are not better described as drugs, foods, or food additives. And those factors are kind of important whenever we get down to explaining this education, that DSHEA of 1994. It may contain metabolites, constituents, extracts, vitamins, minerals, amino acids, herbs, other botanicals, enzymes, organ tissues, oils. It's intended for ingestion and sold in multiple forms. So I want to mention really quickly, because it's going to come back up multiple times in the talk, the Dietary Supplement Health and Education Act of 1994. That was an act that kind of took some regulatory powers away from the FDA. In 1994, I read one article that had stated that the situation at that time is that the FDA was maybe, at least this article felt that the FDA was maybe over-regulating some things that were considered dietary supplements. So there were FDA raids on certain clinics that were I don't know if I want to say prescribing, but sending people out with dietary supplements. And there were also some high-profile court cases that were lost by the FDA in order for them seizing. They were seizing like barrels of black currant oil or something like that. And so that was kind of the situation in which this act was passed. And basically the big part of it was that it took the teeth away from the FDA as far as regulating something before it comes to market. So if it's considered not a drug, not a food additive, then the FDA has no regulatory powers pre-market. So that means that the manufacturer of these dietary supplements is responsible for assessing pre-market efficacy and pre-market safety. So that's kind of the situation that we're in right now. So why are we talking about this topic? As we go through the talk, I'm going to kind of go back and forth between trying to convince you that this is a good topic to discuss in grand rounds. Where obviously this is kind of academic central. So why are we going to be talking about things like marshmallow root and licorice root instead of talking about IBD biosimilars and the pharmacokinetics of IBD biosimilars? Well, there's some good reasons for that, and I'll hope to kind of convince you of that throughout the talk. And then I'll also kind of go back and forth between some, like I said, some charts, some overloaded charts, and talk a little bit about those and the evidence the evidence that we do not have available to support some of these things. So as a first part of the reason why we're talking about this, it's an ever-expanding situation that we're in. The over-the-counter market, over-the-counter medications and supplement options are rapidly expanding. With regard to supplements specifically, it's estimated that there's greater than 90,000 supplements available in the U.S. in 2017. That's a greater than 20-time expansion since the Dietary Supplement Health and Education Act of 1994. It's projected that this is going to be a $60 billion industry by 2025, and that's only in the United States. It's projected to be a $200 billion industry worldwide. And so because there's money in this industry for dietary supplements and other types of supplements, there's going to be production there, and the production seems like it's only ramping up. In North America alone, we account for about 30% of the worldwide over-the-counter market. So what's stocked on our shelves is going to look very different from what's stocked on shelves in other parts of the world. And then in a U.S. survey, there was around 150 million U.S. citizens that report dietary supplement use. That's close to half at the time that the survey was done. 79% of those people that reported supplement use said that they used it daily, and 10% that reported supplement use said that they were using greater than or equal to 5 per day. So these are the parents of your patients. One of the reasons that we're talking about it is because these supplements are not going away. Over-the-counter medications are obviously not going away. This is something that we're dealing with our patients, and obviously their parents are maybe taking one or more supplements, and obviously they're going to be providing their kids with those supplements as well. All right, so again, busy slides. Like I said, I kind of think through things in a chart format. We're not going to go through all of these things, but we're just going to talk about some of the over-the-counter medications that we have available, some of the supplements we have available, and if there's any evidence to support those things. So everybody knows about PPIs. Whenever we talk about PPIs, they do have really good evidence for superior pH control over a longer period of time. Usually we're having for extended release formulations, we have an action of about 15 to 21 hours, depending on if the patient is taking the medication in the right way, and again, extended release formulations. These are indicated for things like erosive esophagitis, peptic ulcer disease, H. pylori, NSAID gastritis, or NSAID prophylaxis in adults for some providers, and then Zollinger-Ellison syndrome. So it has really good evidence to support those uses. And PPIs were medications that were prescription only prior to being over-the-counter medications. And then I didn't really highlight it, and I don't love mentioning this, but there was a really good Cochrane review with a bunch of adults that looked at PPI versus placebo for functional dyspepsia as well. So certainly we can't argue very much about the indications that I mentioned above, but there are a lot of people that are sending adults out with PPI for functional dyspepsia as well, and it seems like it has some benefit over placebo, more efficacy over placebo. But whenever we prescribe PPIs, or whenever our patients are getting PPIs over the counter, we need to think about the adverse effects related to that. So there is the question of CYP enzyme inhibition in the adult world. This is really coming to light a lot more with Plavix or with clopidogrel. And so patients who are taking things like omeprazole and esomeprazole at the same time that they take their Plavix, there's thought to be a significant decrease in the efficacy of their Plavix. And so there's medication interactions there that we have to be aware of, even though these patients may be getting these medications over the counter. And then there's all these questions about short-term and long-term effects that have really come into the literature recently. Community-acquired pneumonia is a big question. There was a big research paper that showed that, especially within the first 7 days of PPI use, that there's a much higher odds ratio of having community-acquired pneumonia if you're on a PPI than if you're not. There's been some subsequent papers that kind of call into question the reason for this, that maybe reflux in and of itself is the primary reason that you're predisposed to pneumonia as opposed to PPI use, but there may be some confounding there. And then long-term side effects have really come into the literature recently, and a lot of providers are a lot more aware of that. Certainly you have a risk for a C. diff infection. There has been shown to be some enterochromatin-like cell hyperplasia, so some hyperplastic changes that are happening within your stomach mucosa. There's fundic gland polyps that can develop over a long period of time. As of right now, that doesn't seem like it predisposes any of our patients to cancer, but that's something that we're watching in the literature for long-term PPI use. And then also there's big questions about calcium, magnesium, and B12 absorption, even to the point that there have been some studies that have looked at fractures. So there was a highly publicized piece of literature out of the UK that listed an odds ratio of about, it was around 1.44 for PPI use over a year. So this is for adults obviously, but patients who were on PPI for more than a year were 1.44 more times likely to have a hip fracture than patients who had not been on a PPI for over a year. And then if you did high dose PPI, that odds risk, the odds ratio jumped up to something like 2.5 or 2.6. And so there's been a lot of concern raised about calcium, magnesium absorption and how if it's affecting bone formation, especially for our younger patients that we're putting on PPI. This was obviously in older patients. There's been some studies subsequently that have kind of called that association into question. The initial study from the UK had a lot of heterogeneity as far as the groups, and there were a lot of risk factors in the PPI group. There were a lot of risk factors for fractures that may confound the results, and so that's something that's kind of ongoing, but it's worth noting whenever we're thinking about putting our patients on a PPI, or when they come to you and they're already using a PPI for some of our older patients. H2 receptor antagonists, we also are all pretty familiar with these medications, I'm sure. I would say that these are generally indicated for pyrosis or heartburn, for uncomplicated GERD. There are some papers that show that they're effective for gastric and duodenal ulcers, for Zollinger-Ellison syndrome as well, but I would generally favor PPIs for that. They're active for a shorter period of time, so they're going to be active for about 6 to 12 hours, and then they have side effects as well, not the least of which is that the patients can have tachyphylaxis, and so they can kind of get used to the medication and their body can kind of adjust to it. You can also have CNS adverse effects, especially with cimetidine, and so I've kind of steered away from that in my practice. And then we get down to things like calcium carbonate, aluminum hydroxide, these antacids, which have similar mechanisms of action. They're going to interact with HCl, and they're going to form some kind of a salt. They may form carbon dioxide, they may form water. And these, again, are indicated for things like heartburn, uncomplicated GERD, and dyspeptic symptoms. Of note, with the antacids, you're going to have a lot more rapid onset of action, so that can be working. For some of these studies, it shows that it works within 5 minutes. And so you get rapid relief, but also you have a shorter duration of action. If you look at some of these studies that are listed in here, you're going to have a pH that gets greater than 3 within 5 to 30 minutes. But as far as the duration of esophageal activity, you only may have 40 to 45 minutes of increased pH within the esophagus. And then for the stomach itself, maybe 100 to 180 minutes. So rapid onset of action, but shorter duration of activity. And then we have to think about some of the adverse effects that can go along with that. You can have, for calcium carbonate, you can have hypercalcemia, you can have milk alkali syndrome, so you have to use in caution if your patients are already hypercalcemic. If they have hypercalciuria or if they have nephrolithiasis. And then aluminum, it kind of exists at a steady state within the body. So if you consume a little bit, then you make up for it with urinary excretion. But if you take aluminum hydroxide over a prolonged period of time, if you're taking it as a regular medication for several months or several years, then you can kind of reset that steady state. And so you may have aluminum toxicity that results from that. And we have to be really careful of that in our renal patients as well. But that's obviously not the only options that we have. There's a lot of other options. As far as bismuth, which is most commonly known as Pepto-Bismol, I was surprised that there's not really a lot of research. You know, in Pepto-Bismol's advertisements, they give basically every indication, every GI symptom is an indication. You have heartburn, indigestion, upset stomach, diarrhea, all those things. And it has really good evidence for diarrhea, as we'll discuss a little bit later. But as far as reflux symptoms or dyspepsia, I really only found one randomized controlled trial that was in adults, which showed some improvement of symptoms. But bear in mind, whenever your patients are taking Pepto, they may have dark or black stools, and then you can have long-term bismuth toxicity, which results in blackening of the tongue and the teeth. Not a great look for our kids. Alka-Seltzer, just bear in mind, this is a really important point. I'll use Alka-Seltzer to kind of illustrate this point, but patients a lot of times will come to us and they'll give us a brand name, and they don't realize that brand name represents a lot of different medications. I've seen it a lot recently with like Docalax. And so patients will come in and they'll say, I'm taking Docalax, but Docalax makes Bisacodal, and now they have their brand name attached to magnesium hydroxide. So you can have Docalax soft chews that are not Bisacodal, they're magnesium hydroxide. And so sometimes patients will come into us and they'll say, I'm taking Alka-Seltzer, but they don't realize that Alka-Seltzer has, their standard Alka-Seltzer, which has aspirin in it. They have Alka-Seltzer Gold, which does not have aspirin in it. And then they have Alka-Seltzer soft chews. Some of them are marketed for adults, some of them are marketed for kids, and those don't have aspirin in it either. So you kind of need to parse these things out, especially if we feel like we're dealing with a patient who may have peptic ulcer disease and they're taking aspirin with that. And if we're taking it in young kiddos, we obviously want to watch out for Reye's syndrome. And then there's a lot of other things that patients have available to them. There's antacid, which is calendula, or a flower found in the daisy family. It has kaolin, which is clay. It has mint in it. There's things like hilma, heartburn, which has chamomile, ginger, marshmallow root, licorice root, artichoke leaf extract. I've tried to, again, for a lot of these things, if there's good evidence available for the actual medication or supplement, I've tried to put that kind of at the top of the list in the evidence category, but for a lot of these, we've kind of had to extract out other studies. So if there's a study that's specifically on marshmallow root in reflux, I've put that in that category as well, but understand that may not be a one-to-one correlation because you're dealing with a lot of different things in there. So for this Hilma heartburn, there was only one observational study, and that was run by the company that manufactures it, which is obviously a conflict of interest. And they have 94% of their patients that are self-reporting a decrease in upset stomach within 30 minutes, but they don't have any placebo in order to verify that how it acts against that. And again, it's run by the company that does it. So there's other, as you'll see there, there's a lot of other randomized controlled trials that look at ginger and licorice and all these other ingredients. And then you can read down through there. Again, these are more meant for not a comprehensive, I don't really want to call it comprehensive, but a semi-comprehensive list. And so these are certainly going to be available to you if you feel like they would benefit your practice, and you can look through and see what evidence is available or not available for a lot of these things that we have for reflux. So whenever we're talking about over-the-counter medications and when we're talking about supplements, we have to talk about self-care or self-medication because this is what patients are pursuing for themselves. Now, initially when I kind of took this topic on and when I heard self-care and self-medication, I'll be honest that I have a little bit of a bias, and I think of it as maybe a negative thing, and I think that's because I want this degree of control in medicine, and I want a degree of control over what my patients are doing. But this is an essential component of our healthcare system, right? right? We need patients and we want patients to pursue self-care and to a degree self-medication, as long as we want to be helping in that process. But you can think about, I thought back to my residency days where you kind of are the arbiter for all medications, and you have, two patients that are crashing over here, and then you're still getting the incessant page for Tylenol because you're the only person that can put in the order for Tylenol. We don't want our patients to have to come to us every time that they need an over-the-counter medication or a supplement. We don't want to write the script for everything that's out there, but we do want to be a part. We do want to be a stakeholder in how they use these things. And there's many factors that influence the practice of self-medication. Certainly age. There's a lot of generational differences, it seems, in how people self-medicate or in how people care for themselves. There's cultural differences. I think about my big fat Greek wedding where they spray Windex on everything. There's cultural differences. There's socioeconomic status differences. In a lot of these pharmacy surveys, they were asking people, why are you using this drug off-label? And a lot of the patients said, because I feel like buying this and using it for my indication that I feel is appropriate is a lot cheaper than going to my doctor and asking them about what this may be and asking them to prescribe something or asking them to give me the same over-the-counter medication anyway. So certainly patients who are at a socioeconomic disposition may be more apt to use over-the-counter medications or supplements, and may be more vulnerable. The location that you're at, the geographic location, and then the political setting. We've already talked a little bit about that when we mentioned that North America accounts for 30% of the over-the-counter market. Therefore, our shelves are going to look a little bit different than other parts of the world. And this is not without risk. All of us know this. If we've been in medicine for a little while, we've probably seen patients who have come in who are treating themselves, who have an incorrect self-diagnosis. They're taking an inappropriate dose of an over-the-counter medication, or they're taking a supplement that you've never heard of. A lot of us have been in the situation where we're Googling something really quickly. I turn my computer screen a little bit away from them and I Google what diatomaceous earth is while I'm listening to them, or what colloidal silver is while I'm listening to the rest of their HPI. There's obviously adverse effects, and this is kind of, believe it or not, this is a surprise to patients. They think that whenever they take an over-the-counter medication or whenever they take a supplement, some of them say that they don't think that adverse effects are possible from these things, which is kind of blows my mind. And there's drug interactions. We think about St. John's wort, and then we've all heard about grapefruit juice and CYP interactions with those. There's drug interactions. And then this is not so much in the pediatric realm, but there can also be dependence for over-the-counter medications. What increases your risk of those complications? Certainly age is a big factor. We have to think about our very young patients, and we don't have to think too much about the geriatric population, but think about the drug labels, the labels that we have on a lot of over-the-counter medications. There's this big age range that's listed on the indication. So you have, if you're 1 to 5 year old, you take 10 mLs or something like that. Think about, a 26-week old kiddo, a previously premature kiddo who still has failure to thrive, who's 1 year old now. He's taking the same dose as a 5-year-old who's in the 95th percentile for their height and their weight. That's obviously a little bit of an issue. Not disclosing over-the-counter use with the PCP. No, there's no way that they're not going to tell you. There's no way that they're not going to tell you what they're taking, all the supplements and the things like that. That happens a lot. Not checking labels. Again, not my patients. My patients are going to check every label that they buy. They're going to read it off to make sure they're using the correct dose for the correct indications. No, it doesn't happen. What about off-label use? Patients using it for indications that are not listed on the medication. Extended duration of use without monitoring. We just talked about aluminum hydroxide and calcium carbonate. We talked about PPIs, some of the long-term side effects that can come from that. A lot of these patients are taking them, and they're either not telling their pediatrician that they're taking them, they're not telling us, their specialists, that they're taking them, and they take them for a long, long period of time. And some patients I've had, they tell you that they're taking them, but then when you try and back them off a little bit, they're really resistant to that, because even though they may not be chemically dependent on those things, they may be mentally dependent upon that because they feel like it provides them benefit. There's also polypharmacy. This is one of the main reasons I got into peds, is because I don't like to think about polypharmacy, but it's a real thing that we deal with in pediatrics. and then not reporting adverse effects. So some patients may not know that their adverse effect is due to the supplement or the over-the-counter medication that they're taking, and sometimes they know about it, but they're not going to tell it to their PCP, they're not going to report it to the distributor, they're not going to report it to the regulatory authority, which is the FDA. And then obviously lack of evidence. This is something big that we deal with whenever we deal with supplements. Do they have good papers, good evidence in order to support efficacy? All right. So another reason that we're talking about this is because this can build a lot of patient-physician rapport. We want to encourage our patients to disclose when they're taking over-the-counter medications. We want our patients to read the labels. We want to guide correct dosing when it's indicated. So when somebody comes to you and they tell you, I'm taking such and such, you have a lot of decisions to make in that moment. Number one, is it safe for them? Number two, if it's safe for them, is it appropriate for the indication that they're using it for? And then number three, if it is safe and appropriate, are they using it in the correct amount? So we want to be able to establish rapport with our patients in order to influence those decisions. So do patients disclose over-the-counter and supplement use? There have been a lot of surveys on this. As you would expect, it's all over the map for these surveys. 20 to 93% non-disclosure. That kind of struck me that 93% of patients in one survey are not disclosing to their physician that they take supplements. And then there was a meta-analysis that looked at a lot of these, and it estimated that the average was probably somewhere around 77% of patients are not disclosing supplement use to their physician. And the reported reasons for that are as you would expect: the doctor's lack of inquiry, the fear of the doctor's disapproval, disinterest, their lack of knowledge in the supplement, their lack of time, and their belief that the medicine or the supplement was safe. We already talked a little bit about this. This also, on one of the surveys, blew my mind that only 8.4% of the patients that were surveyed indicated a recognition that the supplement could cause adverse effects. So a lot of our patients are out there thinking, if I get this off the shelf, there's not a possibility of side effects, because it's certainly, if I can get access to it without a physician, without a pharmacist approval, then certainly it's going to be safe for me in whatever indication I'm using it for, which is false, obviously. So what do you think the most significant factor predictive of non-disclosure is? Of these listed up here, the reported reasons for non-disclosure, what do you think is the most important? Yeah, exactly. We didn't ask. And then in one of these studies, there was an odds ratio of 18.77. So our patients are nearly 19 times more likely to talk about this if we just ask them. And I realize this is hard because we don't have enough time in clinic in order to ask these questions. And certainly if we start getting down that road, we have a lot of biases associated with that. If somebody starts telling me that they're taking marshmallow root and licorice root and things like that, I certainly have a bias to start thinking, oh, okay, I don't really have the time to talk about this, and I don't know if I can trust you to take the medications that I prescribe for you and things like that. So, but we do have to ask our patients. Do patients read the labels whenever they get medications or whenever they get supplements? The FDA requires that medications use a drug facts label. This is something that was established in 1999 to kind of standardize the labeling. It was, at least in some studies, it was shown that it enhances the readability and information, so it gives you a lot of important information up front. And there's good comprehension whenever patients do read the label. So this was a study for omeprazole that basically they ask the patients to read the label, and then they let them keep the label, and then they ask them questions associated with the label. And as you might expect, they answered really well. So whenever they read it seems like they comprehend it. 95% understood what the dose was. 91% understood that it should be limited to 14 consecutive days before consulting a physician. But whenever we look at a pharmacy survey, so whenever they read it, it's good, but what about when they don't read it? There were about 46% in a pharmacy survey that said they were using an H2 receptor blocker for off-label use. So they did not care what the label said as far as the indications for use of the medication. And then 68% of them said that the package label had little to no influence in their decision making. So they were taking it for what they wanted to take it for, in the doses that they wanted to take it in, at the times they wanted to take it, and they really didn't care what the label had to say about any of this. And this was one of the same surveys that talked about socioeconomic status as well, that a lot of these patients were using off-label use because they felt like they couldn't financially afford a visit to their physician. And this was a really cool study by Simon and Winkle, which kind of sounds like a Vegas magic show, but I really like their study design. They did this study, over-the-counter medications, do parents give what they intend to give? So let's say they've read the label, they completed this questionnaire first, and then they did a mock scenario. On the questionnaire, 66% of caregivers reported Tylenol use, but only 8% of them reported acetaminophen use. Again, we go back to kind of this distinction between, a brand name and then a generic name, but also just that lack of recognition that Tylenol was acetaminophen. So sometimes the brand name does a really good job of advertising, and they don't even know what the generic name for the medication is. So there's some education that needs to happen there. And then they did a mock scenario. So after they did the survey, they set these parents up and they let them state what dose of medication their child should get, what dose of Tylenol their child should get, and then they let them measure it out. So only 40% stated an appropriate dose to be given to their child. 60% stated an incorrect dose. And I think it was like a plus or minus on 10% either side. So it was a pretty wide range for a correct dose of Tylenol. Only 67% accurately measured the dose that they intended to give. So patients who gave you the correct dose, or parents who gave you the correct dose, would sometimes measure out the incorrect dose, even if they gave you what was correct as far as what they intended to measure. So of all of the people that did this mock scenario, only 30% produced the correct dose that was accurately measured. That's a little scary that 70% of these parents, even some who state the correct dose, are measuring out the wrong dose. All right, so what about abdominal pain? What kind of evidence, what kind of over-the-counter medications and supplements do we have for abdominal pain? I really like IBGuard and FDGuard. I don't use FDGuard as much. I feel like there's a little bit less evidence for that, especially in the pediatric population, but it seems like there's good evidence for those in the adult population. For IBGuard, there's a randomized controlled trial in peds that showed decreased abdominal pain. There's been a bunch of meta-analyses for adults. And if you look at the numbers needed to treat for some of these adult meta-analyses, it's pretty low as well. The number needed to treat to benefit of 4 is a pretty good NNTB. And then FDGuard, I feel like it's got good adult evidence, and I'll sometimes use that in my functional dyspepsia patients because it decreases, it's been clinically proven to decrease epigastric pain, and a number needed to treat of 3 is not too bad either. There's a lot of other items on here that kind of follow in a similar fashion with IBGuard and FDGuard, a lot that are using peppermint or using caraway oil. And so, again, we kind of have to extrapolate some data. Do we feel like those are as effective as IBGuard and FDGuard? I don't really know because there hasn't been a lot of clinical trials specifically for that, lozenge or specifically for that capsule. But, that's the available evidence for it, which isn't amazing for a lot of these supplements. All right, another reason that we're discussing this topic is to compare advertising claims to the evidence that we have available. So all of these charts that we're looking at are discussing, what the evidence is that we have available. And mind you, the evidence is not just in the randomized control trials that are in the evidence category either. We look at evidence in the mechanism of action category as well. You'll notice that a lot of these things that are further down in the mechanism of action category, it says thought to. And whenever I say thought to, do this, this, or this, that means that there really haven't, at least that I could find, there haven't been any animal studies or pharmacokinetic or pharmacodynamic studies that have really proven that mechanism of action. If you look on a lot of these websites, you'll see something along the lines of, for hundreds of years, this has been proven to, or this has been thought to do this, this, and this. But there's never been any animal trials to prove that that's the mechanism of action. So we have to have evidence for the mechanism of action. We have to have evidence regarding the specific formulation of the supplement or the medication that we're using. And then that helps us to fill in this category of adverse effects over here. And then, does this bottle contain what it claims? We'll talk a little bit more about that as we go along. So whenever we're dealing with the issue of self-medication, self-treatment, we have to deal with direct-to-consumer advertising. So this was an over-the-counter medication that was available, I believe, in the 1930s. It's called Mrs. Winslow's Soothing Syrup for Children. If you, I don't know if you can really see the indications that are listed up there on it, but it says it cures dysentery and diarrhea, will relieve griping in the bowels, instantly cures wind colic. So it sounds pretty good. And this was advertised directly to consumers in the newspaper, in recipe books, and calendars, and trading cards. And some of the other claims that it had, not on the front label, but elsewhere, was that it effectively quiets restless infants, it soothes teething, relieves constipation, cleans teeth, freshens breath, does everything. And then it even said, likely to soothe any human or animal. So you not only can soothe Johnny as he's crying in his bed, but you can take it out and put your lambs to sleep as well. So it sounds like a pretty good thing. And we think, we chuckle a little bit at this direct to consumer advertising because some of the claims seem kind of ridiculous. But we're in a culture where this is still, there's still a lot of things that are going on that you just, I don't know. It's just advertising to our patients sometimes seems more convincing than the counseling that we're providing them. And these are some of the things that they have available to them. Robert Young's acupuncture, superior herbology, tummy rescue for indigestion, bloating, and nausea. I don't even know what's in that bottle, but there's a lot on the label. Whenever you look at organic belly comfort over here, this is a lot of what you see with the advertising. You see that, we've gotten out our natural ingredients of our ginger and our lemon on our mahogany table, and it seems like the chef has just, compressed these natural ingredients into these lozenges, and it's coming to you fresh. Whenever we look down at the advertisement for Emma down here, gently yet fully eliminate bowels each morning, flatten the stomach, crush annoying cravings, enjoy clearer skin, it boosts your metabolism, it improves daytime energy. That sounds like a pretty good life to me. And then we have other things that are, medical associations. This, one of the supplements claimed to have an association with Mayo Clinic, that's made specifically in the USA, that it has major athletic associations with the UFC and the Major League Rugby. If you look at the Gaia advertisement here in the parentheses, it says AKA the right way. So it's made in the right way, and Gaia also has Giselle Bundchen as their new wellness ambassador. I'm sure for her educational criteria. And then this one was really my favorite one down here in the bottom right. This is off of Walmart, so you can buy this from Walmart's website. The new Crohn's half quote, homeopathic formula, stomach and intestinal pain, diarrhea, help stop. So if that doesn't convince you that that's going to treat your Crohn's, I don't know what. But I'm trying to get Giselle to leave Crohn's alone. She can have all the IBS that she wants, but leave us IBD, for goodness sake. What about the reliability of our supplements? This is a study that that scares me a little bit. Erland et al. Were in Canada, and they basically went to the pharmacy and some grocery stores, and they got 31 over-the-counter melatonin supplements, and then they just tested them to see if they contained what they advertised to contain. So the test-derived melatonin content ranged from negative 82.5 to plus 470% of the labeled content. So in other words, if they're advertising that they have 1 milligram of melatonin, that could be anywhere from 0.2 milligrams of melatonin that you're actually getting, all the way up to nearly 5 milligrams of melatonin that you're actually getting. And that may not sound that far off, but when you consider that some of these were 10 milligrams of melatonin, then that's a really big difference that you're getting in the product, especially if you're trying to give that product to your child. And then they also said that 70% of the products had a melatonin concentration less than or equal to 10% of the label claim. So a lot of these were deficient in the amounts of melatonin that they claimed to have. This was another one that kind of blew my mind, the lot-to-lot variability. So if you took one lot of a medication, one bottle of a medication, and then you went, a couple rows back and you got that one that was from a different lot, there could be as much variability as 465%. So we have to question whether these supplements really contain the ingredients that they claim to contain, and then also in the concentration that they claim to contain it. And that's a really hard thing whenever we think about studying these supplements, studying these things. That's a hard thing to standardize. Whenever we go to nausea, we don't really have as many over-the-counter options for that. There's really not any good evidence for Emitrol that I could find, or Nausine Kids. And actually, if you look at Nausine Kids, you pretty quickly find that there's an FDA warning letter that was issued in August of this year that is an unapproved new drug given treatment claims. So the FDA will sometimes do this. They'll look at websites, they'll look at the advertising that supplements are putting out there, and they'll say, you're actually claiming through this supplement that you're treating a condition, or you're treating a symptom in a way that's an inappropriate claim. And so they'll send them these strongly worded letters that have, I don't know how effective they are or not, but they do send these out, and you can find them online. They're public access. And then ginger, I kind of had high hopes for ginger being really helpful with nausea and vomiting. There is a little bit of evidence for it. A lot of the ginger studies are actually really in good patient populations. It's in patients who have had chemotherapy or things like that. One randomized control trial showed that there was a decreased vomiting incidence and decreased school absences. But a lot of the meta-analyses, whenever they looked at it, they maybe found a little bit of benefit in nausea within the first 4 to 8 hours of patients taking it, but then after that, there were really not very many effects, including most of these studies did not show a decrease in the incidence of vomiting, or in the duration of the nausea, or in the severity of the nausea after the first 8 hours. So I was a little bit disappointed that ginger wasn't stepping up to the plate as I thought it would. Again, why are we talking about this topic? We want to educate our practice, so we want to understand what's safe and what's effective for our patients. This is exactly one of those letters that I was telling you about. So this strongly worded letter for Nausine Kids says this product is an unapproved new drug under Section 505A of the Federal Food, Drug, and Cosmetic Act. Significant violations of current good manufacturing practice regulations have occurred, and so they sent a previously strongly worded letter about those violations, and then they said that this is particularly concerning from a public health perspective because it is directed for use in young children. Now, mind you, whenever the FDA sends a letter out about this, that doesn't say anything about the efficacy of the medication. It doesn't necessarily even say anything about the adverse effects of the medication. It's just saying that what this medication is labeled for, what their website claims is inappropriate underneath this Federal Food, Drug, and Cosmetic Act. And this was my first introduction to this, doing these talks, is that these are available on the FDA website. So supplement safety. Again, going back to our surveys, we had a lot of patients who said that they felt like there wasn't any safety issues associated with supplements, but the 2006 Dietary Supplement and Non-Prescription Drug Consumer Protection Act, it mandates the reporting of serious adverse effects. We all know what serious adverse effects are. So, but it was saying that the manufacturer is really responsible for reporting these to the FDA, and we also put a little bit of onus on our patients as well. This act also required that the supplement labels contain the manufacturer's contact information so that if a patient has an adverse effect, they can report it to the manufacturing company. The primary monitoring mechanism for this is the FDA's Center for Food and Safety and Applied Nutrition Adverse Effect Reporting System, or FDA's MedWatch. Note that this is a voluntary reporting system, so patients can go there, physicians can go there, manufacturers can go there, although I don't know how often they do. It was estimated in a study that less than 1% of all adverse effects are reported through this mechanism that the FDA has. So this is the primary reporting mechanism for adverse effects related to supplements, and it's estimated that less than 1% actually filter through the appropriate mechanism. So that was based off of like poison control calls and ED visits. And then enforcement after the fact. So let's say your patient does have an adverse effect that they feel is associated to a supplement and they report it. The enforcement of taking that off the market or checking into it more, the FDA does have that power after the supplement has been released into the market, but that power is often limited by the quality of the reporting that they receive, by seeing a trend in the reporting. They need to see that this adverse effect is not just an N of one, but that there are multiple people who are having this adverse effect. And so the quality and inconsistent reporting is a big thing that kind of limits the FDA's ability to act on some of these things that may not be safe for our patients. And if we think about headlines, there are some things that fall completely into that category. So we go back to Mrs. Winslow's soothing syrup, as we always do, and we talk about the ingredients. The ingredients were morphine sulfate, sodium carbonate, spirits faniculi, and aqua ammonia. So that was certainly going to soothe your baby and soothe your livestock at the same time. Obviously, there's some safety issues there. And we think that maybe that's a thing of the past, but it's not. This was a headline that was put out not too long ago. Death of a Congresswoman's wife points to dangers of dietary supplements. So Lori McClintock, the wife of Congressman Tom McClintock, her suspected cause of death was dehydration related to consumption of white mulberry leaf. So they felt like the supplement was directly related to her demise. It's estimated that greater than 23,000 ED visits per year are attributed to dietary supplements. And that gives us back to that less than 1% reporting number that the FDA is receiving through Sears. Many products and ingredients are not even identified in the databases that are used by poison control centers. So that's really scary to think that you're in the ED, you have a patient who comes in because they've had too much, mulberry leaf or too much, fill in the blank, and you feel like they're having a reaction to that. You call poison control and they say, I don't have any information available on this supplement or on this ingredient of this supplement. That's a difficult situation. How are we doing on time? As far as gassiness, this is probably not new stuff to us. Simethicone, there's been a lot of meta-analyses looking at simethicone. It shows that there's really not much difference in how gassy patients are, how fussy they are, their total crying time. There's not a lot of adverse effects related to that, so I have a lot of patients who come in on simethicone, and I usually don't discontinue simethicone use because I don't feel like there's a lot of danger involved in that, but just be aware. It's good to review the evidence from time to time to say, even though this doesn't pose a danger to our patients with adverse effects, is it really effective, and how can we counsel our patients to adjust their expectations of whether it's going to be effective or not. And then for Colic Calm, again, an FDA warning letter approved that this is an unapproved new drug given their treatment claims. All right, so lastly, one of the big reasons I chose this topic is to kind of mobilize our resources. We really can't do all of this. I mean, if you look, these silly little charts, I spent hours and hours and hours looking at all the randomized control trials and trying to find red raspberry leaf studies in colic and things like that. You really don't have the time to do all of those things. So hopefully these can serve as resources. If you would like to have them, I'm happy to share them. But we can't review all the evidence for these things, unfortunately. Sometimes you have to take it on a case-by-case basis. And patients may not understand that. They don't understand why you may be Googling something in the room while they're talking to you. They don't understand that there are greater than 90,000 supplements estimated in the United States alone right now. But the good news of that is that we have other people to help us. Pharmacists are an invaluable tool. So I would really talk to our pharmacists, recruit your pharmacist whenever you can. If they call you and say, if they're ever touching base with you in order to say that a patient is taking this, then listen to them, take that call and understand what they're saying. Distributor monitoring is something that should be helping us. And so if a patient feels like they have an adverse effect, they need to report it to the distributor. They should be reporting it to us. They should be reporting it to the distributor. And then we, the patient or we, can help report it to the FDA to see if there's a pattern there. And this is how medicine happens. I know this feels like this gargantuan task, this huge task in order to report these things. But you can think about examples in the past where the ball has to start somewhere. Like I think about Floyd and like the lead levels and things like that. If people weren't diligent in monitoring those things and in reporting those things, then a trend never gets noticed. So we have to be diligent in that. There's also a lot of outcry for interfacing between health systems and sites of healthcare delivery. This is a controversial topic, but it would basically be like if your patient went and they bought Pepto-Bismol at the pharmacy, is there something that reports that to you so that you know that they're taking Pepto-Bismol? We're a long, long ways from that, but there's a lot of, especially in the pharmacist arena, there's a lot of advocating for something like that. And then it's an area of needed research. You can see throughout all these charts how many question marks I have, how many no evidence signs I have. So this is an area of needed research, and it's a really difficult area of research. You can imagine if one of the primary ways that we're identifying patients when they are using the supplement is when they're purchasing it. And so a lot of these studies are dependent upon, if you're purchasing this, something pops up that says, hey, do you want to participate in a survey? So we're dependent upon, we have a little bit of volunteer bias there. We have accurate patient reporting biases that enter into these studies. We have placebo effect that influences a lot of our results. So this is a really difficult area of research, and I can't say that I have a great solution to that. We're going to skip over this for the sake of time, and this just goes to show you we're not going to talk about diarrhea. There's a lot of evidence and a lot of different items there. We're not going to talk about any of these other things that you can get over-the-counter medications and supplements for: constipation, probiotics, prebiotics, symbiotics, digestive enzymes, things that are advertised for leaky gut. I mean, there's all these other. We barely scratched the surface of over-the-counter medications and supplements that are available for GI indications. So maybe we'll do another talk on it sometime. But in summary, what about your practice? What are some of the downsides of over-the-counter medications or supplements? It's difficult to verify the validity of the label in some of these supplements. We have insufficient evidence for a lot of these supplements. There's advertising can sometimes be more influential than the counseling that we're providing our patients. There's adverse effects that come with these supplements and with over-the-counter medications. It's often difficult to orient ourselves in an ever-changing sea of over-the-counter and supplement options. But there is benefit. If we demonstrate that there's efficacy to some of these things and there's safety to some of these things, we can expand our armamentarium. I mean, everybody in this room is probably seeing a flood of patients who have GI symptoms, and a lot of those symptoms can be functional. And so if there's things that are safe and effective for our patients against that flood of GI symptoms, I'm all for it, as long as it's safe and effective and proven to be so. It can be cost effective for our patients. It can encourage patient and parent empowerment and ownership of their health. Like I said, one of the main goals in medicine is to get our patients to own their health. We don't want to just be, over top of them deciding exactly everything. We want to be able to have be a stakeholder at the table, but we don't need to control everything. And then medical students and residents, I would say pay attention in Journal Club. This is going to be one of your biggest tools in order to evaluate things that are coming up. This, as we said, this market is ever expanding, and so you need to know how to evaluate evidence and say what's good evidence to support this, what's bad evidence. Dig for those confounding factors, like the only evidence that we have available is by the company that produces the supplement. And then I have some resources. There's the website for MedWatch reporting if there is an adverse effect, or safety reporting portal. And then the FDA does have this good resource, Understanding Over-the-Counter Medicines. So you can send your patients there if you feel like they're not reading their labels or not understanding their labels or things like that. Questions? I'm sorry.
Are you aware if there's a database that compiles like over-the-counter supplements and analyzes them to see the contents or anything like that?
I wish. No, not that I'm aware of.
There is a supplement site.
Is it?
I
missed it.
I subscribe to it. It's a paid subscription. It's a natural.
What kind of information do they provide you, Dr. Powell?
And who's it run
They
by?
list studies and whether or not it's effective, and list potential side effects. And I've used it with patients that have been on supplements with weight loss and stuff, and they'll cite if there's any randomized controlled trials and adverse effects of it. And it's like natural, but it's only it's only supplements. It's not over-the-counter drugs though.
Well, frustration at times, at least when I've had parents bring in a supplement, they'll bring it in, and heck, you can't even understand what the ingredient list actually says.
Yeah.
Right?
Yeah.
So then you're Googling the individual ingredients, and
A lot of these things, I mean, these things are like in double parentheses. I had to look these up. Corporacho, heartwood, and Concord tree, which is horse chestnut. There's a lot of homeopathic medications that it seems like you're doing like a Latin class. They're purposefully trying to sound really academic and smart. But nux vomica and tabacum and all these things, I agree with you. It's hard to interpret the labels sometimes.
It's naturaldatabase.therapeuticresearch.com. and it's a paid subscription to access it. And then there's also a voluntary, more than one, but I'm aware of voluntary places that supplement companies can have monitored and certify that the ingredients in the supplement are what they say they are.
Yes.
And I've seen that in the
I know there
grocery
are
store
those.
supplements.
For the sake of time, I didn't get too much into that. But there are some independent companies out there that are trying to verify contents to make sure that the ingredients are actually what's in there and in the content that they claim, or in the concentration that they claim. Yes, sir.
So being a gardener really helps with a lot of these supplements. So just advocate for all of you to take up gardening. But I think the other kind of patient mentality that I struggle with is I have a lot of folks who love supplements, but then I can't get them necessarily to work on their diet at all, like the cleanliness of their diet. And I'm wondering, what kind of data actually, I think of like IBS, and then I think of this person who's just like eating trash all the time, right? And what kind of data do you bring to your patients with regards to like dietary changes beyond just like the caloric, but really like the food additives, preservatives, things along those lines to help these kind of functional symptoms? Maybe a whole other talk. But.
Yeah, no, it's a really good question. Unfortunately, a lot of that, like this, like asking our patients about this and delving into it is very limited by time, the time that we have available in the clinic. And so I think that's the first thing that I'm counseling them on. I'm much more gearing my counseling towards, as far as a patient who comes in who's not on any kind of supplements that I'm aware of, and they have IBS, I'm counseling them a lot more in the dietary factor and in improving their lifestyle modifications and the factors around that, a lot more than I am recommending that they go straight to a supplement. Certainly with patients with like IBS, on an initial visit, they may walk out the door with a recommendation for like IV Guard for as needed for their pain, but certainly not without counseling that also goes along with. A lot of dietary changes could be much more effective in decreasing the frequency and the severity of your symptoms. I always warn them, though. Especially in the case of IBS, I'm usually saying these are maintenance factors. These are not things that are necessarily going to cure you. If they make your symptoms go away and never come back, amazing. But they're maintenance factors, kind of like brushing your teeth. We don't expect that if you brush your teeth, you're never going to have a cavity necessarily. It just makes it less frequent and less severe. So I try and set that expectation as well, that these are things that are really going to improve your quality of life, and it should improve the frequency and severity of your symptoms, but it may not resolve those things necessarily.
And on that IV Guard, is that the only peppermint oil that because that's the only one with data behind it? Is that the only one you recommend?
This is one I'm using most often
okay.
Because I feel like it has better data behind it. But if there was one up there that I discovered in the research of this, there was one that was for younger kiddos that was called like tummy drops, and it was peppermint oil in lozenges, and I think it had like lemon balm in it as well. I wouldn't be opposed to that if somebody came in, but there are some things that people come in on, like I mentioned it earlier. I had a patient who came in on like colloidal silver. They were trying to decrease their bacterial population within their gut by taking colloidal silver. And I was like, I don't think that's a great idea. I'm gonna put the nix on that. But you have to be judicial in this too. Like whenever we look at the fears and the reservations that some of our patients have as far as why they don't admit some of this stuff, we have to be conscientious of that, because if they do say that to us, they're kind of making themselves vulnerable. And if you squash that in a way that's inconsiderate, you may also find yourself fired from that patient's care. So we try and be considerate.
Sometimes the sources of their information is also like their religious institutions, and so if you squash it, you put them at odds with their convictions as well on other fronts.
Or cultural. I feel like cultural is I've seen that a little bit more than religious. I've seen, my grandma told me to take this, and therefore I'm taking it. And if you squash it, then you're saying grandma's an unreliable source of information, whereas grandma may be their best, counselor for social issues that they're going through.
Culturally speaking, I think because they're not on the FDA regulation, one of the things that people don't realize, you can go on Williamson Road and find a plethora of things that come from other countries, and they are not under FDA control, and they have some very interesting active ingredients, including lead, which it's billed as a medical supplement to boost your, it's got vitamins and minerals, but just not that one. And this gripe water in America, much to my grandmother's distress, does not have the alcohol that the original gripe water that we all grew up on has alcohol in it, but not this Americanized version. So maybe that's why we slept well. But there's
Well, that
lots.
was the syrup of Epicac. The opium that he was. Not Epicac.
Epicac was for
Paregoric syrup, that the opioid.
So this goes more into cough and cold medicines because we run into it, but a lot of these over-the-counter supplements, they're not labeled for expiration a lot of the times. And I don't know what happens to these things the longer they sit, but a lot of people think of, well, I bought this medicine, it's on the shelf, it's good forever. I can take it as long as it exists on this shelf. And I don't know what happens to these things as they age, what peppermint oil turns into over time, and but just making sure, I guess, hey, you need to look at this and see how old this thing is before you.
Yeah, that's a really good point. There's been, I didn't delve too much into it, but there's been a little bit of up and down with like the legislation as well. There was an act that was put forward in 2022 that it didn't seem like it would be that controversial, and it was a bipartisan proposal, but it was stating that companies at least had to disclose what their ingredients were and what proportion they were in to the FDA prior to going to market. But they don't even, and that was not passed. And so they don't require that. There's a lot of things that come to market right now without the FDA ever being made aware of it. And so the burden of finding out that it's on the market, assessing their advertising claims, assessing the content, assessing the adverse effects, all that stuff kind of falls on the FDA post-market, which is, I don't know, it's difficult. It's difficult to kind of assess what the balance is there. But anyway.
So you have a line of supplements coming out that you're...
No.
Is this you're announcing today?
Bursting out of this suit a little bit more, I might advertise something.
Thank you, Dr. Stone. I'm sure if anybody has questions, please direct them to Dr. Stone.
Thank you.